Awesome. Good evening, everyone. Today we are gathered here virtually to discuss the evolving status of the COVID pandemic, vaccines, and the precautions we should be taking to keep ourselves as safe as possible. I would first like to thank Dr. Gans, who's our infection disease expert and has volunteered her time from a very busy schedule today to answer some of our questions. And then I would also like to take this opportunity to introduce and welcome Dr. Michael Rosen, who just joined Stanford as our new IBD director. Dr. Rosen completed his medical education and residency training from Harvard Medical School and Boston Children's Hospital. He completed his fellowship and then served as an attending gastroenterologist, initially at Vanderbilt University. And in 2013, he moved to Cincinnati Children's Hospital. And since then, he has been very intricately involved in the IBD Center. For the past several years, he's been the director of their IBD Center. He's not only active as a clinician and a researcher, but he's also a devoted husband and a father of 2 children and 4 dogs. So because of those 4 dogs, he had to drive all the way from Cincinnati. So Dr. Rosen, please take it away, and we would like to hear something from you.
Well, thank you, Alka. You saved the most important stuff for last. But, it's a pleasure to be here, and I'm very excited to hit the ground running with my esteemed colleagues here with this webinar, and very interested to take part in what I know will be important and informative discussion.
Thank you. And to introduce our panelists, I will start from the very left of my screen. Garrett, who has really worked hard to organize this event. Thank you, Garrett. Could you please introduce yourself?
Yeah, hi everybody. My name is Garrett Forshee. I'm the social worker with the IBD team, and I'm happy to be part of this panel. Probably not going to be talking a lot, but happy to be here as a panelist. So thanks for coming.
Thank you, Garrett. Dr. Gans is our IDs expert, and would you like to just say hello to everyone?
Hi, everyone. Welcome to this evening. It's very exciting to be here, and we really want to make this a webinar that helps answer all your questions. So please do enter into the Q&A and chat so we make sure that we meet your needs during this hour. It's exciting to be here, and I work closely with my colleagues in the IBD population. So I'm really excited to be here.
Thank you. And Sam, who has worked tirelessly. She works behind the scenes, but always with a smile. So Sam, could you please introduce yourself?
Hi, everyone. I'm Sam. I'm an administrative associate for the IBD team, and I help manage their meetings behind the scenes.
Thank you for all that you do. Dr. Ren?
Thank you, Dr. Goel. Yes. Hi, I'm Dr. Red. I'm so happy to see over 30 families here today. And I'm a psychologist on the IBD team, for those of you who don't know who I am, and very happy to see you all here. We've had several town halls related to COVID since about March, April of 2020. And I think this is an incredibly important one, as all kids from preschool, I should say, all the way to college are going back to school. And there's a lot of really important questions. So I'm thrilled that we have Dr. Gans and our amazing IBD faculty here to help answer everyone's questions. So I know some of you sent them in before and Garrett shared them with us, and I see others are writing them in the chat now, which is wonderful. So we'll be monitoring and making sure that they get answered. So please feel free to keep writing questions as you have them.
Thank you, Dr. Ren. So let me start without taking any more time, start asking Dr. Gans, what is the current data of infection rates in children? Are they still getting mild illnesses, or children are getting more ill with this current variant of COVID virus?
Thank you for that important question, Alka. I think it's very important to always keep this in context. The rates of childhood COVID infections, and we detect that either whether you're symptomatic or not. So if you go and get a test done, so some children are just being tested because they've been in proximity of somebody, so are not symptomatic. The number of cases has gone up, as has all the cases in our country. What's important to realize is we peaked in this country in January. We have not reached levels as we did in the previous peak. However, we are a little higher than our previous peak in the summer of last year. And so the rates are climbing. As you know, adults have the opportunity to be vaccinated and children do not. So the rates in children are going up a bit, only because proportionately they are actually the ones that aren't fully protected by vaccination. So the rates in children have increased from about 14% of what we typically had seen in all the previous increase in cases to about 22%. So not a huge increase, but going up anywhere from 7 to 9% over previous weeks. So they are increasing. I think the important thing to realize, and sort of within your question, is what does disease look like in children? And I think this is a really important question, because infection just means you have the virus in your body, but maybe it's not causing you to get sick. So the disease in children still does tend to be on the side that wouldn't require someone to come into the hospital. So again, you can get symptoms, you might feel ill, but you're not severe enough to actually bring you to the into the hospital. Of all the cases, there's still anywhere from up to 2% of the individuals who have been tested positive of children who will make it into the hospital. So have some component of their disease that really gets them into the hospital. But most importantly, what we've learned in the pandemic over these years and with all these spikes, we are really learning better how to treat it and to keep people from actually progressing from that point that they even hit the hospital to death. And it is true that children are very much likely to actually pass away from having a COVID infection. And it's really down in less than 0.01%. So very, very few people who actually test positive for that will then have some of these outcomes. And again, we're getting much better at understanding how to support people who are infected.
Thank you. So let us start with school safety. And I think the most vulnerable population we have right now is children who are immunosuppressed, who have IBD, but they are under the age of 12 and have not yet been able to get vaccinated. Some of the concerns parents have raised to us are whether their child should receive virtual education, is it safe for their children to attend school, and what do the parents do when the rest of the children do not wear masks, especially during lunchtime or open recess time? How can parents protect their children?
So another great question, and something that we're always trying to understand all the risks that go into this. And I understand how difficult this decision is for families to really understand what is the best way to help my child in this situation. I think what's important to know is children really do benefit from some sort of in-person educational experience. It has really been shown that over this period of time of a virtual learning, that children actually aren't engaging in the same ways that they do when they're in person. They also obviously need the social effects. So I think people just really have to gauge how their child is doing would be the first thing. But those experiences have been shown to be very important for children, particularly very young children. And then I think you have to take it in the context of sort of what the school is doing. So if I could recommend to the families to find out what your schools are doing. So what are the safety measures? We have a lot of studies that have been done and will continue to be performed with the current variants, but have shown that if schools take a number of steps, actually going to school is very safe for children. So what I would recommend is finding out, do they require vaccination of their teachers and staff, and anyone over 12 who is eligible to be vaccinated? Is that something that schools are requiring, encouraging, and how are they tracking that? What are any testing measures that schools might have in place? Because several schools will provide testing. How are they dealing with the ventilation in the classroom? So this is very important. Are they distancing students at all, or is that not? Is there masking indoors, and what is the masking policies outdoors? So these are all the things to find out. And what I would suggest is, once you find all that out, if you feel comfortable, you can also share with the school the status of your child, that your child maybe is more vulnerable to becoming more ill if they were to be exposed or infected with the virus. And if you share that with them, maybe there's things that they can help you understand better for your child and how to position them. So one thing, for instance, would be to see if your child could be placed in a safe location so they can unmask and have lunch. I would also suggest that your child continues to be masked both indoors and outdoors, despite what other children are doing, if you decide to send them to school. The other thing that is very important is obviously hand hygiene. So if children are sharing art supplies and other things that I think are wonderful for children, again, to experience, whether at school, just very good hand washing. Provide your child with a hand sanitizer that they can use at most instances during the day. And just educate your child about how, to keep themselves safe. But I would really urge you not to spend a lot of time telling your child about dangers or other things. We don't want to really cause anxiety in our children. We just want them to say, I think some of the habits that we all have are really good, like washing your hands. And if you can, in an unmasked situation, not be near other people. I would ask your school to accommodate your child if they are having to remain masked when other people aren't, to allow them some distance time alone to actually be unmasked during the day. And that can happen fairly safely. So these are all the things you can start thinking about. If you have particular questions about your school, feel free to reach out to your pediatrician, who has been dealing with sending all children back to school, so should know a lot about your particular child, their circumstances. But it's really a risk balance, which we think in this current status, even with the Delta, is really mostly sort of weighted on the side of being an experience that they should have. If, having said all that, you're still not comfortable, I think virtual is a great option if it's available, if that is something that you decide. But this is a very personal decision about risks and benefits.
Thank you. And now sorry, Dr. Reddy, you were saying something.
Whoops, so sorry. If it's all right, Dr. Goyle, I want to make one comment and note of reassurance about the risk of severe COVID, that is hospitalization, needing intensive care, and death in patients with IBD on IBD medicines. And that's, although the medicines, many of the patients that we treat for inflammatory bowel disease are on medicines that work by modulating the immune system. Thankfully, we have a lot of evidence thus far that the vast majority of those medicines, patients are not at higher risk, including children, of more severe disease, of contracting COVID, or of having more severe COVID on these medicines. And there's one major exception, which is higher dose steroids, such as prednisone or prednisolone. But for the most part, the other medicines that we use to treat inflammatory bowel disease, although they do affect the immune system, do not increase the risk of contracting COVID or for more severe COVID.
Very important point there. So moving on, we now want to focus on those children who are 12 and over, I have received some questions from parents who are not sure if their child should get vaccinated. So I came across some parents who are worried. They've researched on the internet that those children who are on biologicals or immunosuppressive drugs should not be getting the vaccine. And then also, if you could address that having gotten the vaccine, what safety is it providing to the children? Should they be still observing some safety measures while at school?
That's a question for me, right?
Yes.
Yeah, thank you for that very important question. I think it's very important for people to understand how incredibly well studied these vaccines have been. And hopefully with that information, people will feel assured of how safe they are, both in the general population, but as Dr. Rosen says, there are actually some studies, even including children in these age groups in the IBD group. So I do think it is important, and I think it's great that Dr. Rosen brought up that the disease rates outside of not having vaccination, but the vaccine is in the general population incredibly safe. We now have we have millions and millions of doses that have now been studied in people. So when I say studied, the original studies, which were also some of the largest studies that have ever been done for vaccines, including tens of thousands of individuals, we have real-time data that is safety data that is being run through multiple sources that actually is currently looking in real time at some of the adverse events that happen after vaccination. So now after millions of doses, we have an incredibly huge database of what happens to individuals who get these vaccines. So this is what allowed us to actually move from an emergency use of at least the first vaccine that came before the FDA to actually be licensed. This is more information than we've ever had for a vaccine that's moved to licensure. So that should really reassure people that this disease is new, but the mechanisms at which we used to actually study it are not new. And the science that brought us here has been rigorous and has not been compromised in any way by time or the fact that this is novel. So I think we should just really rely on the data that we have, which is amazing. And we feel so fortunate actually in the scientific community to actually have these amazing systems in place. So having said that, this has been very well studied and continues to be monitored in people 12 and above. They're actually in the original sets of individuals who the original, right now, the licensure goes down to 16 years of age. So you can certainly be assured of that. And I think that that will quickly go into younger children. There is some data on the safety of a very, when we say transient, I mean temporary condition for children 12 to 15 years of age who got vaccinated and then did have some cardiac events, all of which went away, and all children actually recovered with those actually spontaneously. Nothing was done for them, although many of them did go into medical care because we wanted to monitor them. So the good news is that we know about all that. The other good news is that individuals who have gotten these vaccines have actually done very well. The other thing that's important, so safety is really not something that we worry about for the messenger RNA vaccines that are available for children. The other really good news is that at least in the populations, I think to go along with what Dr. Rosen said about the disease in those children, so if they get natural infection, the vaccines actually have been pretty effective in the groups that have been studied. So there's been 3 studies that have been done in children with inflammatory bowel disease. I'm sorry, in people with inflammatory bowel disease, one of which did include children. And the preliminary data is that an incredible number of them. So in the 90s actually responded to that. So that's actually really high and much higher than other individuals who have any kind of suppression of their immune system. So I think that that is really promising, that these vaccines will be very protective. In the general population, these vaccines, while you can always get breakthrough infection, that's not what vaccines are made for, to sterilize somebody. You can always get infected. But what's amazing is that even in individuals that you might expect to have severe disease, they've actually been very well protected against hospitalization and severe disease. So we're very excited about that. And I think that for all individuals, the best policy of protection comes from a vaccine. You really don't want your body to see the virus and then get exposed that way for immunity. You really want to do it in this safer way, which is highly protective. And so not only would I suggest that children and adolescents, young adults who have inflammatory bowel disease get vaccinated, I think is very important for everyone in the household to also be vaccinated. That's another really important way that I think we'll talk about in a minute, all the things that the family can do to also help protect children in their household.
And should the vaccinated children be observing masking, social distancing, and the usual precautions that unvaccinated children have to observe in school?
Yeah, I know that as wonderful as these vaccines are that I just talked about, and I know how exciting that is for individuals to get vaccinated and perhaps be able to, then not have to mitigate in other ways. That is not the recommendation for individuals who have immune systems that are suppressed. We still would like to see them continue to mask, social distance if you can, to have good hand hygiene, and so to continue some of the what we call mitigation or prevention strategies. Those are so highly effective. And just to give you a sense of, these are highly protective of other infections too. So our rates of influenza this year, for instance, have been very strikingly low. So it's just a great way of helping protect someone who might need a little bit more protection than other people. So it's important to uphold those policies.
You're very right. I think the protection from influenza and other respiratory viruses has been amazing with the use of masks. So moving along, many parents want to know what can they do. So there are some parents who have been vaccinated and others who've still not been vaccinated. So how can they keep their children safe in the current environment?
Yeah, this is such an important question because I think we as parents have a huge opportunity to provide a safe environment for our children of all ages. And this is very important. So anyone who is eligible for vaccination should be vaccinated. That includes all vaccines. So we're encouraging everyone also to get the flu vaccine this year. And that it should be available to all families, and obviously all other vaccines that are available to you. The other really important thing, and I think this was something that I wanted to say about school, but as well as social situations, you should think about social situations for your child still in the context of there is transmissibility of this virus going around. So we're not in a low transmissible time. It's high transmissibility. So I know we all want to socialize and to get together, and we've, really not done that for a great period of time. And there was a lot of hope with the vaccination of populations. The US population is still only about halfway vaccinated. And so there's just a lot of opportunity for this virus to continue to transmit. So we still would take precautions with social gatherings. We wouldn't have those social gatherings, particularly indoor social gatherings, and particularly gatherings that include a lot of children who aren't vaccinated. If you want to gather with people that you know who are vaccinated, and you can plus or minus have them tested, then, I think you're creating an environment where you could possibly be with people in a safe way. And so really consider those social events. You have to consider large gatherings for your child, and that's what I was going to say about the school. If you do feel able to tell your school about your child's status, they can tell you when they're having a full school gathering or something that you may not want your child to partake in. So those kinds of large social gatherings, particularly if they're indoors, but even if they're outdoors, if you could separate your child and have them social distance, that would be the best scenario for those cases. So it's both about social, so inside the house, and also when they maybe are going elsewhere.
Great, thank you. And another question for you, that in this high transmissible environment, supposing a child who is immunosuppressed because of IBD actually gets exposed to an individual with active infection, what precautions or treatments or prevention do you have in place at the present time?
Yeah, this is a very important question because, again, as we've had this pandemic for year and a half, we've actually learned a lot of things about how to protect people. And one of the most important sort of strategies we have is to protect really early on when you've been exposed. So this is another way, again, by telling your school that your child has a suppressed immune system, they might be able to give you very early data about any exposures. So any exposures that your child has, whether it's at school or in the community or wherever that might be, you should really contact your IBD team because we might be able to partner with you. It just depends on how old your child is and how much they weigh, but we might be able to actually give them some strategies to help protect them after they're exposed, regardless of whether or not they've had the vaccine. We would consider thinking about their exposure. So every case is going to be a little different, but we do have some strategies that we would love to offer to you and your children if you are exposed. So please let us know if that were to happen.
So Dr. Gans, would you recommend testing first, supposing somebody gets exposed? Is day 2 or day 5 of testing the right way to start, or using preventive measures like medications be the better way to start?
Well, testing is going to be important because we want to know your status, but some of the strategies that we have in place are not reliant on testing, so we don't actually, they're reliant on exposure rather than infection. So we want to protect you. So I would say if you were exposed, call your team and we can help you navigate the testing and navigate any strategies that might be available to your children.
Very well, thank you. And a lot of questions we are receiving is regarding the booster shot.
Yes.
So, just like, it has been approved for children or individuals who've been immunosuppressed. So what is your current guideline for patients who are immunosuppressed regarding their booster shot?
Yeah, thank you for that. One thing that I should point out, I think this is going to be the theme of the night, which I actually think is a great theme because your children who have inflammatory bowel disease seem to be handling most things very well, as Dr. Rosen pointed out. The other thing that they handle very well, and we didn't talk about this, is the side effects to this vaccine are actually less in our inflammatory bowel disease population. So, again, most of the side effects that we see, so fever, sore arm, things like that, are a result of your immune response, or not a result of the virus, actually. And so because, their immune system is slightly suppressed, they actually have less side effects. So that's another good thing, but they respond very well, as we talked about. In the population of inflammatory bowel disease, you are considered someone who's more suppressed than other people. And so a third dose, which is actually not a booster dose for people who have immunocompromised, there are several populations that have been tested, most notably in solid organ transplant. It's a different situation than yours, but I'm just telling you this because this is where a lot of the testing for that third dose has happened. have been shown that they're not responding as well to the primary series, which is a series of 2 doses. And it's not unusual. It's also not unusual to give additional doses of a vaccine to populations that don't respond as well. So for instance, all of our childhood vaccines have a different schedule than adult vaccines because children in general need a little bit more priming of their immune system to actually have a good response. I will tell you that we are recommending that children who have any suppression of their immune system, who are within the eligible age group to get vaccinated, do receive that 3rd dose. And in studies that have looked at that 3rd dose, they actually do really well. So again, not a lot of side effects to that 3rd dose. So it is something that probably all of us will need eventually, and we would like to offer it to individuals who may need it first, which is children and adolescents who are in the age groups that can get it. So yes, please do
Dr.
get.
Gans, it should be 28 days after, like it could be supposing the child has received the 2nd dose of vaccine 1 month back. Can they still go ahead and get the booster dose, or they should be waiting a certain period of time before they should go for the booster?
Yeah, great question. The recommendation right now is actually to get the 3rd dose anytime after 28 days from that last dose. So you're from your 2nd dose of the messenger RNA. Is there a benefit to waiting longer? That actually has not been studied. And the feeling is these are not boosters, these are 3rd doses. So these are doses just to catch people who haven't responded fully. So the idea is that you may actually need a booster at some period of time. But the good news is certainly your team here, everyone can follow you along and find out when that might be. I would caution that we don't actually know what level of immunity you need to this virus to be protected. So that's called a correlative protection, or the level that we're assured that if you get exposed, you're not going to have, you might get infected again. These are not sterilizing, but to get disease. We don't have that data. Actually, for most of our diseases, we don't have that data. So what we do have is we know how effective they are. We know how when people get these, they don't show up at the doctor or the hospital. And these are highly effective. And we just want people whose immune systems are a little bit lower to actually have the same effect from having gotten vaccines. And that might take 3 doses in some people.
Very well, thank you. And there was a question in the chat, if you could address that, about where to get the vaccine. I think CVS is offering it. You can schedule it from CVS by going to cvs.com. And we do have some sites. Best thing is to go to your primary care physician and get some directions. Is that correct, Dr. Gans, or is Stanford Children's Hospital offering some special clinics?
Yeah, Stanford Children's Health actually does have a couple of clinics that are giving this dose. It's not as broad as you would think. So I know our Sunnyvale site is up and running, but I think it looks like Rachel knows. Rachel, do you know where these are being given?
Yeah, no, for sure. I'm in the Sunnyvale clinic today, but
there you go.
So they're giving it down here. But I think it's pretty easy to make a vaccine appointment through my chart on the app. So I think if you want to get it through us at Stanford, you can make an appointment for the vaccine online, or again through anywhere that's giving the vaccine. You simply just don't need any special documentation about your medical history or about your eligibility, just to go ahead and bring your record from prior vaccination so that they know it's been at least 28 days since your last dose.
If I think that's an important point that Rachel brings up. While we have supplied letters to our families, you don't need that in order to make an appointment at the pharmacies to get it. So, but if you have any obstacles, obviously reach out to your team. We do have those letters available to you if you want them.
And another question that comes up sometimes is from the parents, like if they have younger children who are unvaccinated, but the parents have received their vaccination. At the present time, my understanding is they do not need booster shots. Is that correct?
Right. So unlike in the population whose immune systems are suppressed getting third doses, those would truly be both booster doses. We just assume people have responded to the first primary series, whether you got the messenger RNA, which is 2, or the Johnson & Johnson, which is 1. We assume you responded to those because most people did. And so those truly would be a booster. So at this time, there's no recommendation for people to get a booster. The CDC and the FDA have decided that boosters will be available to the rest of the population. And then the group that decides how this is being rolled out is meeting to decide how it's going to be rolled out. And it's going to be staged because it's going to be 8 months after you completed your other series. So obviously people got it at all different times. And again, as Dr. Benson said, you'll just have to show your card when it is available to you. It is not available to you now. And because there is no real reason that you need it. So I think that that's really important.
And another question that comes up from some families, so for example, their child is on Remicade infusions. Does it matter about what should be the gap between the infusion and the vaccine? For example, they've got the infusion today. Can they get their vaccine tomorrow, or should they be waiting till just before the next infusion to get the vaccine?
So people who are on chronic immunosuppressive drugs, so drugs ongoing, I think that becomes less relevant exactly when that boost is. If there's a period of time that your care team, so I would definitely reach out to your care team because they're going to know your full story, what else you're on, how often you are, how immunosuppressed you are. If there's a cadence to your immunosuppression that your care team thinks you're highly immunosuppressed 1 week and not the next, although that's not typically how these medications work. I mean, they're trying to suppress you sort of at a baseline, then that would be the time to get it. But I wouldn't really focus too much on that. It's really a net immunosuppressive state that your child is in. So not this sort of waxing and waning. I don't know if anyone in the IBD team would think about that differently.
The only drug that we sometimes have that issue is with steroids, because steroids are given at a certain dose and then we wean them off. But as far as other infusions are concerned, like Remicade or ustekinumab or vedolizumab, we don't consider that immunosuppressive anyway. But those medications, we maintain a certain trough level for them. Otherwise, they don't remain effective and there's a risk of antibody formation. So you're right that the level of immunosuppression does not really wane. Does Dr. Rosen or Benson, do you have any thoughts on that?
I think in general too, I recommend just getting it when you have the opportunity to get the shot. Yeah, in terms, not the timing with, there isn't great data to inform the timing around shots or infusions. And I agree with you, Alka, that if you're on steroids and we're anticipating you coming off of those steroids or getting to much lower doses and your immune system being better able to respond, then I wait until we are able to get to either low doses or off of steroids.
Yeah, I would say that anytime you have what would be an enhanced immunosuppression, so let's say you have a flare or there's something that your medications at baseline go up, that would be, so that's usually like steroids or something like that. I would agree that the most intensive states would not be a good time if your future state would be lower.
Right, exactly, especially if we anticipate it being temporary. And we always hope that our steroids, especially at higher doses, will be a temporary state.
Okay, now, I wanted to focus attention on our young adults, the 18-year-old and over, who are either already in college or are headed to college. This is a very exciting time of their life, especially when they're freshmen and going to college for the very first time. So what advice do you have for them, Dr. Gans? What precautions they should be observing? Let's hope they have gotten vaccinated. What should be they doing during classroom times, meal times, social gathering?
Yeah, I think that recommendation, college life, is obviously a very intense social time. And so I think that your young adult just really needs to understand that they are at increase, and this is COVID or non-COVID, they are at slightly increased risk of infections than other individuals. Obviously, the outcomes in the inflammatory bowel disease group has been okay, but I would say that a lot of the early data that we have on COVID is at a time when people were largely quarantined and all the mitigation was in place. So that's what we know works. And so even when you're going off to college and you're vaccinated, you probably need to continue while there's high transmissibility. So the idea is that while the virus is transmitting, hopefully we all get to a place where this isn't relevant any longer. But if your child's going to a state where there continues to be high transmissibility, then you really need to think about that. The most important thing is, what is the school doing? So most colleges actually have been fairly thoughtful about how they're bringing people back. So they should be, again, asking about requirements of the students in terms of vaccination for any of the professors or teachers or staff that are there. So these are things that you can find out about the college and just understand the environment in which your child is entering into. I would suggest that your child try and have meals and social experiences outside if that's able to be there, and then you can find that out also from the school. Find out about their rooming situation, and if possible, find out about their roommate. People don't have to necessarily disclose information to you, but again, if you feel comfortable disclosing to the school that your child has an immunosuppressive condition, then they hopefully will be able to at least give you some information. So it really doesn't change for that child. I would make sure they're vaccinated. That's your best strategy for protection against disease with COVID.
Very well, thank you. And then one burning question that I think many of us have is, when are the vaccines for younger children likely to be approved? The date has shifted a little bit. Do you know some inside story that the rest of us are not privy to?
Yes, thank you for that question. I was just answering another question. You can look at it. I'll just announce it to the group. It's the Prevent COVID research study that actually is looking at teens and children for the individual who's interested in that.
Haley, can I add one thing? I think a
Please.
lot of the initial clinical trials were including healthy children, but there's post emergency authorization studies that are including data on our IBD population and on lots of others who are also immunosuppressed on similar medications.
Yeah, and most of that data is safety. So those are in the safety data links, but I think the Prevent COVID is actually looking at the immune system of children.
Thank you.
Yeah, but yeah, I think that's really important what Dr. Benson brings up. We're studying this in real time as individuals in the inflammatory bowel disease of all ages are getting these vaccines. They're being studied forward in terms of safety data points. So an incredibly safe vaccine in 1, 2, and 3 doses so far. Sorry, Alka, now I forgot. Oh, yes. When are we expecting for younger children? I know, we all want that. Well, I do sit on the FDA advisory committee for biologics, and so I have been following that very closely. So it's important to know that the studies in children are very important, because what we actually did learn was that children's immune systems can be stimulated by much lower doses of the vaccine virus. And so the children who are below 12 years of age will be getting a third of the dose. So in the current vaccine, I'm talking about Pfizer because they're the furthest ahead. Moderna will come, these other vaccines will come, but we know the most about Pfizer just because they're ahead. Anyway, the dose in down to 5 years of age is actually a third. And then in the very young children, it's actually a tenth. So it goes 30, 10, 3. So it was very important to do those. We had to figure out the dose that would stimulate a child's immune system to correlate with what we see in adults. Because again, we're not going to probably have efficacy data. That means we don't know how many children necessarily will get COVID or not, because hopefully those events are very rare. So we have to have different data for children when we look at their immune response to the vaccines. Those studies for Pfizer will be completed at the end of September. So the important thing to realize is we don't fast track these. So everyone can rest assured again that we're waiting for at least 50% of children in those studies to actually reach 2 months. 2 months is the time at which we started looking at all the other vaccines for emergency use. And the reason why that's important is because we have a lot of information on vaccines and adverse events, and the adverse events happen in the first 6 to 8 weeks that would happen in that close proximity to a vaccine. So we require that time period to pass before we are bringing these before the committee. So that will be at the end of September. So Pfizer has finished enrolling children, and now they're following them for those data points. One important component that is being assessed, and I don't know if the parents on this panel know about the entity that's called MIS-C, so that when children get naturally infected, there is this delayed effect of having been infected with the virus, and that has happened like 6 weeks later. So we want to make sure we have that period of time to the vaccine so that we have that data safety point, which is different than the adult studies. So that is an important time point, and that's why we're waiting. So again, the idea that any of these are fast-tracked are really not consistent with the strategies that have been used to bring these to market. And again, the number of people who are being tested is far greater than we have with other vaccines. So we feel very comfortable with that, but we just can't shortcut it.
That's really, really helpful, because many people are really waiting for young children. And I think last but not the least, what is your sense? Are these vaccines really helping with the new mutations? What about the future mutations? What do we know today? I know this virus is still evolving and there are things we don't know about it.
Yeah, so this virus is this virus is just like other viruses in that it mutates. That's what viruses do. So when they replicate, they have the opportunity to change their structure. That's very classic. The good news is this virus is actually more stable than other viruses. So the flu virus or other viruses that circulate are much more likely to mutate, which is why we need flu vaccines every year. This virus is a little more stable. The reason why we're seeing variation right now is because so much replication. So remember, the whole world is infected with this. And so we're just seeing a lot of replication that's allowed to happen. The good news is that all of the vaccines that have been studied are protective against the variants that we know of now, so the known variants. The dominant variant that is in this country is called the Delta variant. And that variant does have several changes to one of its proteins, which is the target of the vaccine. The good news is when you get the vaccine, so I'm just going to make these numbers up, but you see like 53 sites of that, and you make antibodies to that. Well, about 13 sites have been changed on the Delta, but you still have all those other sites where it binds, and so it's highly effective. And that has been looked at both for what's called our antibody responses, which most people know about because they're easy to study, but actually the more important immune cell that is part of your response is called a T cell, and those also have been highly effective against the variant. So all that is maintained so far. As Dr. Goyle says, we don't know what the future holds, but we feel optimistic. So as long as we can get people vaccinated and get the transmission down so it's not replicating, this is a more stable virus. So that really bodes well for the future.
Really do want to thank you for your time. And Dr. Benson and Dr. Wren, are there any questions in the chat that you've come across that you'd like to address now?
I'd like to bring up one or two from the chat. One question, which I think I can answer, is there were a number of questions about which medications make someone immunosuppressed in our IBD population. And so therefore, which should everyone with IBD receive a third dose, or should it be just those patients on immunosuppressive medications? Haley, please correct me if I'm wrong. Generally, it's those who are on immunosuppressive medications, not just having IBD. And so our immunosuppressive medications are biologics, but also some of our oral medications like methotrexate, azathioprine, mercaptopurine, tofacitinib, as well as steroids. Those are all immunosuppressive. So all of that group, whether medicines are oral, IV, or injected, would be a reason to get a third shot. If you're on diet as therapy or mesalamine, then we wouldn't consider you immunosuppressed. And then we would not necessarily need to go ahead and get a third shot. But the question to you, Dr. Gans, is that, well, one, make sure you agree. And two, is a great question from one of our families. It was if they were fully vaccinated before starting immunosuppressive medications, but are now on an immunosuppressive medication, would that be a reason to get an additional dose?
Yeah, no, that's a great question. So first of all, I think Dr. Benson explained it very well. I would agree with the categories of those people who are suppressed or not. If you are wondering about a third dose in any context, please contact your care team, and we could also look at your immune response to vaccines. The caveat with that is we don't fully, as I said before, we don't know what the protective level is. So we don't want to give people a false sense of security either. I think what we're looking at is breakthrough disease and other disease metrics. So that's more important when we don't understand fully how your immune system protects you from this. So we can always answer individualized questions. I think it's really hard to individualize every scenario that all of your children are undergoing. If you were vaccinated before becoming immunosuppressed, I probably would get a third dose, because while you might have had an adequate response initially, there is an impact on the circulating immune cells that are there that would be available for memory responses. So remember how this works is that you make a response, but you need circulating cells there to actually respond to any exposure. So we are exposed to whatever we're vaccinated against, and then our immune system kicks in. If you have less cells available to you, you might not actually have a very robust ability to respond. And what a third dose might do is bring those cells that are memory cells that maybe are in your lymph nodes or other places and actually expand them. They may have been suppressed, and so there's low numbers of them, and you want to get those numbers up. So I think it would be important and beneficial to your children, even if they were vaccinated prior to starting an immunosuppression, to get that additional dose to kind of make them remember.
And if I may add to that, besides the drugs that were mentioned by Dr. Benson, I would say even drugs like Euceris or budesonide, which we think are less immunosuppressive, but they do have, some of them do get absorbed and have some immunosuppressive effect. So you should consider the booster dose even for those children.
I think we're really lucky to have a vaccine that is so well tolerated with so few adverse events, and is really, again, the way you want your body to be exposed to this virus. Any bit of viral replication in the tissues of your body, can have so, you'll clear it, you'll get better, you'll do whatever, but we don't know sort of the effects on your tissues. So I would say having the vaccine doesn't allow you your tissues to see any of the infectious virus. So it's a much better way in general, but including with this virus, to become immune.
Well, this was a wonderful discussion. We've all learned so much from you, Dr. Gans. We cannot thank you enough. Dr. Ren, did you have something to say or from the chat? Otherwise, I will let Dr. Rosen finish the session today.
Yeah, no, Dr. Benson, you picked the last ones, and then the Q&A questions have been answered too. So thank you guys all for sending your wonderful and very important questions. I think they've helped the whole group here. And thank you, Dr. Gans.
Thank you.
Thank you.
You're muted, Dr. Rosen.
Thank you. Okay. I'd like to also extend my gratitude to Dr. Gans for educating us all on this virus and the vaccine. And also a big thank you to Dr. Goyle for walking us through this journey for the last hour with such competence. And also to all the families at home who are participating, who brought such fantastic and important questions that are not just important for you, but I'm sure also important to all the other folks on the chat. So thank you all for making this such a success.
Yeah, thank you everyone for coming. We understand what a challenging time this is, and we just want you to know we are here for you.
Thank you. And
Thank
this
you.
brings us to the end of this session. Thank you, Sam and Garrett, for arranging this. It went smoothly. No computer glitches. Thank you.
Be safe, everybody. Bye.